Good afternoon, everyone. At the outset, I would like to thank the organizing committee and Dr. for providing me the opportunity to present here today. So, I'll be talking about management of refractory allergic eye disease. As we know, ocular allergy can present to us in different ways, and there are several therapeutic modalities available out there for the management of these patients. Despite this, even when we see a patient of ocular allergy, even though we know what the patient has and we know how to treat the patient, we still see a subset of patients who don't respond the way we want them to, or they end up developing severely. And an important reason for this is the fact that these patients are not correctly classified. So, what happens because of this is that the patients are either undertreated or overtreated. For example, a patient who has an intermittent disease which is mild may get repeated courses of steroids and develop complications because of the chronic steroid use. And on the other hand, a patient who has a chronic disease may not get adequate medical therapy and have frequent relapses. So there are several classification systems in literature which help us classify these patients, and correctly categorizing them is very important. So over the course of my talk, I will be focusing on the chronic form of ocular allergy, which is defined as allergy which relapses within a month of stopping medical therapy. So when a patient presents with an acute phase of allergy, the first line of treatment is topical steroids, and based on whether the patient has a moderate or severe disease, we can give them a surface steroid like loteprednol, etapronate, or severe steroids, potent steroids in severe disease with prednisolone acetate. Usually a short course of 4 to 6 weeks is given to these patients. Other medications that are used during the acute phase include antihistamines and mast cell stabilizers. Now, these are the most commonly used medications. The first two are mast cell stabilizers. They have a slower onset of action, but the efficacy is there for a prolonged period. Levocapastine is an antihistamine. These are very rapid, but they have a very short duration, and the effect is over within 4 to 6 hours. And by and large, these medications are not used in chronic ocular allergy. The next group of drugs, these are the dual-acting drugs. They combine the effect of both antihistamines and mast cell stabilizers. But if you think about it, the immediacy of these medications comes from the antihistamine part, and that part is anyways covered by the topical corticosteroids. So once again, these medications are perhaps superfluous when we see patients of chronic ocular allergy, and just mast cell stabilizers in isolation may suffice with the corticosteroids. Now, because the patients have chronic disease, they will require maintenance therapy, and here topical calcineurin inhibitors are the drugs of choice. And they also have a delayed onset of action. They start somewhere between 6 to 8 weeks, and so it is imperative to give the patients corticosteroids in the acute phase. The effectiveness of these medications has been established in literature, and head-on trials comparing cyclosporin and tacrolimus have found that both have similar efficacy. But tacrolimus is an ointment. It has a once nighttime dosage, and overall the discomfort with tacrolimus is lesser, so it is easier to use this medication in children. This is a case example of a patient with moderate VKC with limbal variant, and the patient was given topical steroids, mast cell stabilizers, and tacrolimus, and the patient had a very good response to the same and was kept on a maintenance dose of mast cell stabilizers and tacrolimus. Now, why this particular combination of medication is preferred? To explain that, let me take you back to the pathogenesis of VKC. So, as we know, VKC primarily begins when there is an exposure to an environmental allergen, and this initiates an IgE-mediated inflammation. And how VKC is different from the rest of the allergy is that this is not the only mechanism at play, and there are several other pathways, of which the cellular pathway is the most important one, since it causes structural remodeling. So, the mast cell stabilizers act by suppressing the IgE-mediated inflammation, and calcineurin inhibitors directly inhibit the T cell activity, and so they act on this half of the inflammation, and that is why together they are a very effective combination for maintenance therapy in these patients. Now, counseling is a very integral part of management of patients with ocular allergy. Both the patients and the parents must be explained about the chronic course of the disease. We have to advocate against self-medication with steroids, and of course avoiding IOC. Now, I will just discuss in brief about the sequelae of ocular allergy, the most common of which is shield ulcers. This again can have different grades of severity. The milder ones are treated with medical therapy, whereas the more severe ones require debridement with or without an amniotic membrane graft. Now, this was a patient who was managed with medical therapy and showed a very good response. Sheet ulcers typically occur secondary to giant papillary conjunctivitis, and managing this is just as important. And the conventional mode of therapy is with supratarsal steroids. But it is important to understand that when you give supratarsal steroids, the disease can recur within 6 months of the injection. So these patients have to be kept on very close follow-up. And if the patients have repeated attacks, it is a good idea to give these patients oral immunosuppression. Now, this was again a patient who had received multiple injections from elsewhere and presented to us with exuberant giant papillary conjunctivitis. And with a course of oral steroids and cyclosporin, the patient had a very dramatic response to complete resolution of the papillary conjunctivitis. Now, this was the other modalities include excision with the replacement of the perineum with either a conjunctival autograft or nipple contained graft. Now, coming to the sequelae of nipple variant, we have LACD. If the central island is clear, you can give the patient a scleral contact lens, and if there is total LACD, AIOC2023 is the treatment of choice. These patients do very well, just a minute. And keratoconus is yet another association. Here, keratoconus progresses very quickly and they require Slexel earlier. Cataract and glaucoma, these are things that often get mixed, and we have to be on the watch for these entities as well. I'll just So, to summarize, it is very important to understand the classification. What is the type of disease that the patient is presenting with? Irrespective of the type, all patients require counseling. We have to advise against eye rubbings and avoidance measures. Using antihistamines in isolation or muscle stabilizers in isolation is not sufficient for moderate or severe chronic ocular allergy. And these patients will require short courses of topical steroids during the acute phase. If it is not responding to this, topical calcineurin inhibitors and then subsequently oral and systemic calcineurin inhibitors can be added. And finally, in the last cases, severe cases, patients will require surgery. And it is important to refer these cases to higher centers for the appropriate therapy.